Hi everybody. Let me start by thanking for this opportunity. We'll discuss about role of electrophysiology in unexplained visual loss in children. These are objective and non-invasive technique for evaluation of visual function and to differentiate between disorders of retina, optic nerve and visual pathway. The advantage is that it's possible from early days of life and requires no subjective input from the patient. We'll discuss about different type of electroretinography, electrooculography and visual evoked potential. A full field ERG records the generalized electrical response of the retina and helps in distinguishing whether the rod or cone system is more affected or whether the dysfunction appears at the level of photoreceptors or after that. Multifocal ERG assesses the function of multiple discrete area of the central retina, mainly from the cone pathway and commonly used in cases of hydroxychloroquine toxicity, retinitis pigmentosa and Stargardt's disease. Pattern ERG is particularly important. It records the function within the macular region and it emerges largely from the ganglion cells, that is the N95 component, with contributions from photoreceptors and bipolar cells, that is P50 component, and helps in identifying any cases of retinal ganglion cell dysfunction. Pattern ERG in combination with other recording can help in finding out the site of dysfunction. That is a normal pattern ERG with normal pattern VEP is suggestive of non-organic cause. If the pattern ERG is normal or only N95 component is abnormal along with an abnormal VEP, it's suggestive of optic nerve dysfunction. An abnormal pattern ERG with a normal full field ERG is suggestive of maculopathy. If both are abnormal, it's generalized retinal dysfunction. Electrooculography records the functional integrity of retinal pigment epithelium and its interaction with outer retina, classically used in confirmation of Best's disease, and an ardent ratio of less than 1.65 is considered to be subnormal. Visual evoked potential assesses the conduction along the optic nerve and the functional integrity of the visual pathway up to primary visual cortex. It can be recorded even in preterm infants starting at 24 weeks, and if we want to localize the impairment along visual pathway, we need multi-channel VEP with additional electrodes. There are three types of VEP. A pattern reversal VEP is most preferred because it gives a less variable waveform and timing. Pattern onset offset VEP is used in case of malingering and in patients with nystagmus because it's less sensitive to poor fixation, eye movement or deliberate defocus. In case of poor vision or poor cooperation, we use a flash VEP. Coming to applications of VEP in predicting the visual acuity, which is empirically done by determining the smallest pattern size that elicits a just identifiable VEP. In case of amblyopia, we get a diminished or absent VEP in cases of smaller pattern. In children with visual impairment, VEP is either unrecordable or recordable only to a larger pattern or flash stimuli, and thus help in ruling out malingering. In case of diseases of anterior segment or ocular media like congenital cataract or corneal opacity, a flash VEP should be done to rule out severe macular or optic nerve lesions to prognosticate the eye before planning for surgery. In case of visual pathway lesions, VEP helps in detecting a subclinical dysfunction and establishing degree of the functional loss or to monitor any progression or improvement in the disease. Coming to delayed visual maturation, this condition is characterized by infant appearing to be behaviorally blind at a young age in which the child doesn't fix and follow with no ocular or CNS abnormality which contributes to the visual loss is found out and usually recovers by around 5 months. If the condition is associated with seizure or mental retardation or perinatal insult, it can take up to 1 year or more to recover, but it gradually improves. In such cases, both flash and pattern VRP are present and normal when compared to age-matched control. Though some children might show abnormal VEP, but it gradually improves. In case of CVI, a normal flash ERG is seen with abnormal flash VEP. In case of acute cortical blindness, this flash VEP should be done, which helps in predicting the prognosis of the disease. It also helps in monitoring patients who are at risk of visual complications from disease or therapeutic intervention, differentiating between visual inattention in a child from abnormal vision, differentiating between static and progressive encephalopathies. Coming to inherited retinal disorders, it can be either stationary or progressive as shown in the slide. In these cases, ERG is particularly important because it has both diagnostic and prognostic value, and it should be correlated with the fundus finding and other investigations like OCT as and when required. In many cases of inherited retinal disorders, the fundus can be absolutely normal, as in case of congenital stationary night blindness or achromatopsia, or in early cases of Leber's congenital amaurosis or Stargardt's dystrophy, which are commonly seen. So even when nothing looks wrong, an ERG should be done, which can give a clue. In case of congenital stationary night blindness, an electronegative ERG is seen with a large A wave with an absent B wave, as we see here. Fundus albipunctatus, which is a subtype of congenital stationary night blindness, is characterized by delayed dark adaptation. Here, ERG shows abnormal rod response, but usually get normalizes after a period of adaptation, as we see the lower waveform. In case of rod monochromatism, absent cone response is seen, but rod response will be present. In case of S-clone monochromatism, normal blue cone and normal rod response are seen. In case of retinitis pigmentosa, usually both A wave and B wave are diminished, but the amplitude of full-field ERG is proportional to the area of functional retina which is present in such patient. Leber's congenital amaurosis contributes to about 15% of congenital blindness. Here, electrophysiology shows an undetectable flash ERG in early age with a variable flash VEP. In Stargardt's disease, in early stages, the full-field ERG appears to be normal, but pattern ERG usually appears to be abnormal or indistinguishable. But in case of advanced stages, in full-field ERG will also be abnormal with an abnormal rod and cone response. In case of Best disease, EOG is the test of choice, and usually EOG shows an lower Ardens ratio, usually less than 1.5. Coming to another use, this electrophysiology can also be used in predicting the visual field in children, especially in small children or children who are having intellectual disability, in which testing visual field might be challenging. Thank you.